Welcome to the ECGs and remote monitoring session organized by International Arrhythmia School, chaired by Dr. Eugene Crystal and Dr. Ratika Parkash.
Morning, everyone. Welcome to the our session of International Winter Arrhythmia School. It is unfortunate that this time again we had to switch to digital format. First of all, I want to say everyone thank you for coming, and I want to say happy Valentine's. I'm not counting anymore number of winter schools or international arrhythmia schools we made so far, but I suspect that the next one will be number 20. So happy Valentine's, everyone. Welcome, and we're grateful for support of Sunnybrook and the Women's College Cardiology divisions, and as well as for all our sponsors. So today's session will be fairly short and will be focused on ECG and remote monitoring. I would love to introduce Ratika, who will be co-chairing with me this event. Ratika is a professor of medicine at Dalhousie, and she is famous for her research in electrophysiology, and more recently and particularly in device management remotely, which would be one of the topic. Ratika, please.
Thanks very much, Eugene. I have the distinct pleasure of introducing our first speaker, Adrian Baranchuk from Queen's University. He will be talking about infrequent ECG patterns. As you know, Dr. Baranchuk is sorry, it's hard to. Dr. Baranchuk is a master and guru in ECGs. There's no question about that, and in many other things. And in fact, I hope he's able to stick around for the program, because I will be talking about one of his areas of specialty in cybersecurity in the remote medicine talk. So with no further ado, we'll let Dr. Baranchuk begin his masterclass in ECG patterns.
Thanks, Radhika, and I have to say that that was the most lovely introduction that I got since the beginning of the pandemic. I'm truly pleased with this introduction. It has been recorded, and I will play it several times in order to refresh myself how you see me. And I would like to start saying that it's a true pleasure to be able to be part of the speaker group today at the Winter Arrhythmia School. This became a classic that Dr. Crystal and his team have been placed for all of us. And in this opportunity, I'm sharing with Professor Newman, with Professor Parkash, and with Dr. Anthony Cashew, who are three very motivating speakers. So I'm really waiting for you guys and your presentations. In order to make mine more attractive, I am presenting to you the three aspects of the ECG that I am more interested: the P wave, which is a Cabernet Sauvignon 2020, the QRS by AB, which is a Malbec 2017, and the QT, which is a Malbec 2019. And with this, we have completed the initial part of the ECG. So the next wines from our line will be exploring other aspects of electrocardiology. Remember, drink with moderation. And I know Dr. Newman is laughing at my recommendations. All right, so the intention today is to review very quickly 5 ECGs so I can leave more time for the rest of the speakers. So what I'm going to do is, usually this could be an interactive session with me asking you what this is. Given the online format, I'm going to go through it, trying to mimic if you were doing some sort of analysis of it. So this is the first ECG. There will now be clinical data on that. So as you can see in this ECG, this is lead 1, and the last one is lead V6. You have the mix of narrow complex beats preceded by a P wave, followed by 2 fat QRSs, and that is a sequence. These 3 beats, then these 3 beats, then these 3 beats. We refer to this as group beats. So when you have group beats, a lot of mechanisms producing this type of rhythm disorder come to mind. So first, pay attention to what are you dealing in the sinus beat. It is a relatively low voltage QRS that is narrow. There is no conduction disease, slow R wave progression in the precordial leads with a borderline PR interval and a relatively long P wave, but nothing that catches our eye. Then you have a first fat beat. And in order to distinguish whether this is a premature beat coming from the ventricle or the atrium, you check if there is a P wave before that. And as you can see, there's no P wave preceding the QRS, making this more likely to be a premature ventricular beat. Now, when you have that and you have many sequences, in order to determine the mechanism, it's very good to see the coupling interval, which is the interval between the first fat beat and the preceding normal beat. And as you can see, it's always identical. If the coupling interval is variable, the mechanism of the fat beat could be increased automatism, and this is competing focus towards the sinus one. So basically, the coupling interval is variable. But when the coupling interval is fixed, the most likely mechanism is ventricular reentry. And then you have a second bit with a quite similar morphology to the prior one, where it happens the same thing. The coupling interval between the preceding bit and the second bit is identical in each sequence. So here you have two identical intervals, the coupling interval and the interectopic interval. And then from the first PVC to the next PVC, that interectopic interval is also identical. All this resembles then a reentrant mechanism. So what you have here is sinus rhythm with a ventricular couplet. But I'm pretty sure that Dr. Newman is saying, yeah, but this is not why you brought this ECG, because he's looking at this tiny wave after the QRS, very highly visible in lead 1, which is inverted, and then a second one where the distance between the ventricle and the atrium is longer in the second beat. Remember, every time that you see an outcome progressively coming at a longer distance, Wenckebach phenomenon is something that you have to have in mind. And remember that Wenckebach does not occur only in one direction of the AV node or in one direction of the electrical system. It can happen in any direction. So what you are looking here is a ventricular couplet with progressive VA prolongation. And if we have a third fat complex beat, maybe you may see no P wave after that, completing the sequence pattern. So is this Ashman's phenomenon? No, we don't think this is aberrancy, given given the lack of P waves before the white complex beats. And that rules out basically the first two. Is it a pacemaker failure? No, this patient does not have a pacemaker. So these are ventricular couplets with ventriculoatrial Wenckebach. Let's move to case number 2. And while I'm talking, I will give you a few seconds to reflect on this ECG. Basically, one of the recommendations is take a look to all the leads when they are available, because some of the leads may give you the hint or the clue. My small homage for the Queen's people to Dr. Peter Munt that has referred this ECG to us a few years ago. So, and what it calls the attention on this ECG is that classic sawtooth pattern that could make you believe, lead 3, lead 2, that this patient is in some sort of 4 to 5 to 1 flutter. However, a detailed look to the rest of the ECG is in lead 1, you see the P wave followed by a QRS. There's no flutterish waves. In the precordial leads, you can see this plus minus P wave indicating some degree of left atrial enlargement, but there's no arrhythmia. So how is that possible that you see something that looks like a typical flutter in some leads with sinus rhythm in the other one? Is this atrial flutter with variable block? Well, it's difficult is difficult to accept that you have a part of the atrium in flutter and another one in complete normal sinus rhythm. Is this atrial fibrillation? No, there are intervals are done regular. Take a quick look. Irregularity is one of the patterns that we see associated with atrial fibrillation. Is this AV-NRT with 2-to-1 conduction? No, because the P wave precedes the QRS. By default, this is artifact due to Parkinson tremor, and I challenge you to tell me which arm is not shaking with the rest of the body. And this is more likely to be the left arm being quiet, allowing you to determine the single normal lead sign, which is a very good tip to distinguish between real arrhythmias and artifacts. Before we start case 3, please use your chat function if you have a question regarding this ECG you don't want to forget, and if we have time, we can answer it at the end. And I asked the moderators to give me a 1-minute warning so I can wrap it up exactly at 20 minutes. Normal sinus rhythm, P wave is followed by a QRS. QRS is preceded by a P wave, very low voltages. So when you see very low voltages, a few things should come to mind. Is the thorax too big, so the distance between the electrode and the heart is large? Is the myocardium being infiltrated as it happens in amyloidosis? So those are things that quickly should come to mind. But here you have an RS-R prime pattern with a QRS less than 120 milliseconds. This is an incomplete right bundle branch block that goes along left axis deviation, 1 and AVL. 1 is positive, AVF is negative. This is way to the left, but this is not an inferior infarct because you have a tiny R wave in the inferior leads. So this is a combination of incomplete right bundle branch block with left anterior fascicular block. What else calls my attention? There's T wave inversion in lead 1, 2, B3, and B4. So now if I put together that I'm dealing with a Canadian patient with an ECG in sinus rhythm, with incomplete right bundle branch block, left anterior fascicular block, low voltage, and T wave inversion from B1 to B4, from which region of Canada you think this patient is? A little prize for whoever unmutes and says the region. Keep in mind that that prize could be one of the wines that you saw in the first slide.
Newfoundland.
Very good. And there is a wine coming to Dr. Newman, so please, Dr. Crystal, make all necessary arrangements. And he's saying that because in Newfoundland, there are several families that are presenting with arrhythmogenic right ventricular dysplasia. So I have amplified here V1, V2 for you to see also that tiny little sign there, which corresponds to an epsilon wave. So kudos to Dr. Newman that knew what this was way before I said this patient is Canadian. ARVD, right bundle with left anterior, low voltage T wave inversion V1 to V4, epsilon wave. Number 4, and now we're getting into the cool ECGs. Take a look. While you're doing that, I'm opening the chat. Newfoundland, Nova Scotia, Newfoundland. Oh, guys, drop bit that is regarding your first ECG. Eugene was, I will answer this slide lately. Very nice. Thank you for all your comments there. Absolutely fascinating. So I'm pretty sure that some of you also see that this another example of group beats. One sequence of 3 beats, 3 beats, 3 beats, and 3 beats. So let's analyze this sequence. I have 2 spikes, one in the atrium producing an atrial depolarization, one in the ventricle producing a ventricular depolarization, very wide QRS. Someone quickly can tell me where is the RV located in the right ventricle? V1, V2, V3, V4, V5, V6. Is this a septal position? Is this a CRT or is this an apical position? I know you know, guys, that when you have this QS pattern from V1 to V6, this is more likely to be an apical position, but this is not why I brought this ECG. There are 2 beats where you have atrial and ventricular capture, And then there is a third beat in a sequence and a pattern that seems to be a spontaneous beat without a P wave preceding it. So this is a premature ventricular contraction. And as it coming preceded by 2 pace beats, this is a ventricular trigeminy, 2 normal pace beats, 1 with something funny, but starts clearly before the atrial spike hits. And I'm pretty sure that you all already realize that the atrioventricular space of this beat is shorter than the AV of the regular pace beats. And when the device shortens the AV pace, that is called safety pacing. Why the device does that? When the device depolarizes the atrium and there is a signal in the atrial channel that is recognized not as an atrial depolarization, in order to secure pacing, the device quickly shortens the AV delay to try to secure capture. But what happened here is that the second spike does not produce a capture. Why? Because the PVC maintain the ventricle in the refractory period. So you're pacing over a refractory period chamber. Why the safety pacing was activated? Because a big portion of the PVC is depolarizing after the atrial lead has kicked in. And that is the window for the safety pacing. And why the atrial lead kicked in? Because there's no atrial activity. So this lead is not reading what happens to the ventricle until it kicks in, and part of the sensing occurs in the vulnerable period of the atrial lead, triggering safety pacing. Is this a failure to capture? No. When you try to depolarize a refractory ventricle, that is not considered a failure to capture. It's a physiological phenomenon. Is a sensing failure? No, because there was no atrial activity. So the pacemaker did well in pacing the atrium. Isn't an RNT algorithm? No, that's not an RT algorithm. I don't need to explain it. This is ventricular trigeminy plus safety pacing. I have amplified here for you to see how the spike of this PVC is falling in the window where the paced atrium is recognizing signals that are not coming from the atrium. And I'm going to finish with this lovely ECG that for most of you has no tricks. This is a short PR interval with a delta wave. Look in V4 how nicely you see short PR plus delta wave. So one could simply say, yeah, this is a pattern of a pre-excitation, of a ventricular pre-excitation due to an accessory pathway. So the lovely thing here is that the ECG can tell us where the pathway is. So when Eugene goes to ablate it, he knows where the pathway is located. And very quickly, if you have an R wave in V1 mimicking a right bundle branch block, the pathway is in the left side. Subsequently to that, as 75% of the accessory pathways are in the left lateral region, you have to look at 1 and AVL looking for a negative delta wave. But in this case, delta wave in 1 and AVL are positive. This is not in the left lateral. Subsequently, you go to the inferior leads and you have this pattern frequently confused with an inferior myocardial infarction due to negative delta waves. So to finish, this is not an inferior MI. This is not right ventricular hypertrophy. This has nothing to do with the Brugada pattern. This is a left posterior pathway, short PR interval, delta wave, and the pseudo inferior infarct pattern. So I am stopping here and happy to take questions. Thanks for your attention.
Thanks very much, Adrian. Are there any questions from the audience or the other panel members?
There is a comment in the chat from Eugene, and he says, doesn't Wenckebach requires drop beat? This is regarding the first ECG. In order to have the full sequence, yes. Here, as we didn't have 3 beats to show that, one speculates the VA is prolonging, and that is a Wenckebach phenomenon. but strictly speaking, you're absolutely right.
Adrian, just a quick philosophical question. Obviously, when ECG was invented, we did not have intracardiac pacing devices. Would the composition of today's 12 leads be affected should we reinvent the standard ECG now? What is your thought on that?
If I understood the question well, are there or should we think in different ways of obtaining non-invasive ECGs, right? Because if we compare the surface ECGs with the plenty expanded methodologies of mapping the heart, obviously there are intrinsic limitations to the technique.
My question is a little more specific.
Oh, go ahead, go ahead.
Would you change the regular 12 lead composition? Would you move any of electrodes? Would you obtain something else instead of, for example, V6, right? Or something.
Okay. Now I got it. So basically, it is a philosophical question. Why? Because attempts to expand the classic 12 lead ECGs have been published extensively in the last 10, 20 years with unipolar leads, with the 15 leads, with changing the algorithms for automatic detection, and now with artificial intelligence. So all these things happen. What has happened with the classic 12 lead ECGs? That it has go through times of imaging, of simplifying images, and nothing so far was able to replace the classic 12 lead ECGs. And one of the keys is that now the 12 lead ECG is not an area of knowledge of few gurus or masters. Now you have expertise in emergency doctors that have changed the paradigm of how we understand the ECG of ischemia and stop calling STEMI versus non-STEMI to bring new terminologies. This is now an area where neurologists are very interested because the 12 lead ECG can tell them what patients are going to be more likely to present with recurrence of stroke after they have seen one. So this is expanding in different areas where the interest is not being accompanied with strong knowledge. So what is the role of people like me? I am invested in education, and this is why I want to learn from Kashu, Newman, and Prakash today, because they are teachers. I need to learn more to see the things differently as how I conceive it in my mind. Am I close to new techniques? Oh no. I mean, non-invasive electrocardiology merging ECG with imaging is fabulous. It's excellent, but still has not progressed the niche of the 250 people that can interpret those things. And you can buy it. You can use it in your center, Eugene, and to have a non-invasive ECG imaging device. The point is that now we are reaching thousands and millions of individuals every day via Twitter, teaching a single 12 lead ECG that is the same ECG that Wenckebach and Movitz were discussing more than 100 years ago. So philosophically speaking, if you ask me, my interest is to reach the largest possible audience and to transfer the largest amount of knowledge that I can figure out, and to leave for the bright minds the evolution and how you say that, the development of new techniques that will be complementing this area of knowledge, or eventually at some point replacing it. In my time, I don't think that I will see it, because still the 12 lead ECG fascinates so many people in the world, people that is entering the force that wants to learn from it, that I'm going to invest my energy trying to help other educators to have a stage and to share more and more knowledge.
That's excellent, Adrian. I mean, really interesting when you think about ARVD and how the ECG could be used differently in trying to detect ARVD more accurately on ECG rather than having to use MRI and so on. And the definitions may change over time, but I think Eugene asked a very poignant question, because using high lead through Rugata and all of those kinds of applications are out there. Now, there is a question here that I can see from Martin Strauss. With safety pacing, was the first spike through the atrium or the ventricle?
The first one is the atrium. But it's a lovely question because when you see these variations of AV delay, one of the possibilities is that the atrium dislodge into the ventricle and pacing the ventricle directly. But if you've been able to retain the image, in the two first beats, the atrium is capturing the atrium, and in the third beat, the PVC starts before the delivery of pacing. So indicating as the AA interval remains constant, that the atrial lead intend to depolarize the atrium. You don't see it because obviously the voltage of the PVC is masking the atrial activation, so you cannot see it. But indeed, the first spike is the polarization in the atrium. And remember, for safety pacing to be activated, the first spike has to be the atrial lead. It doesn't matter in which chamber it is. The first spike for the pacemaker is the atrial lead.
There's a cute, not used very often, but it's a bit pompous. You can call the first beat pseudo fusion because it's an atrial spike into a QRS, and the second beat is pseudo fusion, a ventricular spike into a QRS. Old-fashioned terminology.
I love old-fashioned, and people that like Dr. Cashew that we interact a lot in Twitter knows that I'm a little bit of a pain, because when people comes with new terminologies that have never been extensively published or recognized in the community, I spend my 20 seconds in Twitter just to correct the terminology. And some people doesn't like it. I understand. I mean, it can be painful if a guy is only there to say, hey, I couldn't call this that way because that sign has never been recognized as per the name of the author, right? ECG terminology is not a semantic problem. It's way deeper than that. When we confuse the terminologies in ECG, we end up confusing the interpretation of the case. And that's why I ask people to stick to the traditional terminology, and of course, to acquire new terminology as science accepted. And that is the reproduction of multiple papers using a new terminology. Thanks, David. Nice observation.
Okay, we continue with the ECGs and remote monitoring sessions organized by the International Arrhythmia School, a virtual session especially for ECGs lovers with updates on remote monitoring. In case you have questions, please feel free to put them in the chat function, or if you would like to talk directly to speakers, please raise your hand with the raise your hand function in your Zoom control panel. Our technical team will then unmute your microphone so that you can speak to speakers yourselves. I'm handing over back to the moderators to introduce the new speaker.
So thanks, and I think it's a good time to move to Anthony Cashew, who is a research fellow in Rochester in Mayo Clinic. He is internist, and he is a very passionate ECG teacher. Anthony, please.
Thank you so much. Give me a moment and I'll share my slides here. You know, it's very hard for me to follow up on after Dr. Baranchuk. Everything I'm going to share today is all because of what I've learned from those that have come before me. And so it's always humbling to learn from someone and, you know, even follow someone that I've learned a lot from. So I want to thank all the organizers, Bensi and Drs. Prakash, Baranchuk, Crystal, and Newman for inviting me and to share this virtual stage with all these experts and to share a little bit of the ECG and acute coronary syndrome. My name is Anthony Cashew, and I'm a cardiology fellow at Mayo Clinic. And so I've divided this into 4 parts, okay? And so hold on to your seats because there's a lot we're going to cover here. And in each part, there's going to be 4 key points that I'm going to leave you with. And so it's going to be less case-based as Dr. Baranchuk did, but hopefully this is a good change. In part 1, we're going to look at the ECG and ACS, kind of lay the foundation. We're going to talk about STEMI, the end-STEMI dichotomy, the subtle ischemic ECG features that we should be able to recognize, and then end with some non-ischemic STEMI mimickers. And so we'll start at part 1, the ECG and ACS. And so the first point I want to leave you with is that many patients with ACS do not manifest any signs of ischemia on the ECG. And so when we think of acute coronary syndrome, we divide it into unstable angina, STEMI, and NSTEMI. And when we think of MI, it's really the STEMI and NSTEMI. And so we'll focus on these two here. And NSTEMI we define as acute MI, AMI, without diagnostic ST elevation. In STEMI, this is essentially different definitions that have come out, but you're essentially looking for ST elevation relative to the J point or to the PQ junction in at least two contiguous leads, and those cutoffs vary. Now, there's specific sex-specific criteria limitations based on these cutoffs that we won't get into all those here, just based on the content. So when we look at STEMI, we think of the pathophysiologic substrate of acute thrombotic occlusion, ATO, with the risk of irreversible myocardial loss if not urgently treated. And so when we think of ATO, acute thrombotic occlusion, that's based on the TIMI flow grade that they use, and TIMI is thrombolysis in myocardial infarction flow. And so 0 is no flow, up to 3 being flow. So they tend to grade this from 0, 0 to 1, 0 to 2, or very high percent acute stenosis. But if you review the literature, that high percent of acute stenosis is not really well defined. And many would say that the NSTEMI actually has a similar pathophysiologic substrate if not treated. And so looking at these two, we can see that STEMI requires the presence of ST elevation, whereas NSTEMI could have ST elevation, but not meeting that diagnostic cutoff, or a number of other patterns. But there's many patients with acute MI that present with negative or what we call non-diagnostic ST elevation on the ECG. And so when we look at the acute coronary syndrome, those latter two, the STEMI and NSTEMI, are separated based on the ECG findings. So there's a study that was done in JAMA in 2001 that looked at how well does the ECG do to diagnose AMI. They use CKMB, so not the angiography or troponins that we use today in the clinical setting. And they had ECGs that were interpreted by the treating physician. And what they found were 8% of those ECGs were normal. So these are all patients with MI. 35% of those ECGs reviewed were non-specific, meaning non-diagnostic ST elevation, ST depression, or T-wave inversion on them. And there were 57% that had diagnostic findings of MI based on the ECG. And so as you can see, only 57% of those had that. The 35% that were non-specific, well, we usually don't hear much about them. So there wasn't much detailed reporting on those findings. And those that are diagnostic may actually be diagnostic to maybe one of our expert panelists here that could see them, right? And so there's also likely confounding variables in findings, such as left bundle branch block, left ventricular hypertrophy, and many others. And so there's limited studies that actually assess the non-diagnostic findings that may actually be subtle ischemic features. And so when we think of those diagnostic ones, the 57%, well, they could have ST depression or T-wave inversion that's diagnostic for ischemia, but not actually acute thrombotic occlusion. And then that 35%, well, they may be diagnostic, but have actually STT abnormalities that may or may not be due to ischemia. So that whole 35% group is that heterogeneous group of various comers, and we call them NSTEMI. And we know that ECG features have prognostic value. We know that diffuse and profound ST elevation of more than 2 millimeters in consecutive leads is a high mortality, right? We know that T-wave inversion during pain is a lower risk, whereas after pain, it's a higher risk feature. And so there are ECG features that we know that warrant reperfusion therapy. Here's left bundle branch block with Scarbosa criteria, hyperacute T waves, De Winter T waves, Wellens type A and B, left main coronary artery occlusion, or at least stenotic left main. And then the posterior STEMI, or at least ST depression in the right precordial leads. And so of those 35%, there's little work clarifying and differentiating other aspects of non-specific ECG features that warrant reperfusion therapy. So key point number one is many patients with ACS do not manifest any signs of ECG, of ischemia on the ECG. And so part two, we're going to look at the STEMI and STEMI dichotomy. And we know the main point here is that acute MI, AMI, is dynamic because the pathophysiology is dynamic, and therefore the ECG findings will be dynamic. And so you could think of maybe part of the problem here is this dichotomy where every pathology actually has a spectrum. Some think of this acute thrombotic occlusion spectrum, and knowing that AMI is a dynamic process, well, that means that the ECG pattern can vary based on when we actually record that ECG. And so if you look at this, okay, a patient coming, they're doing fine, they present to the hospital at that 0 hour, and they're occluded, their vessels occluded. We give them some anti-anginals, maybe antiplatelets, and what happens is they start to autolyse that coronary occlusion, and by hour 2, they're reperfused. But then they start to thrombose again, and at 6 hours, they're occluded again. We look at the first ECG on presentation. Well, there's non-ST elevation. The second one, non-ST elevation. The third and the fourth also showing no STEMI criteria. The troponins, were elevated on presentation, continue to stay elevated, but increased over the next few hours. And so what do you do next, right? We have higher troponin that's trending up, non-ST elevation. The patient is not having any refractory symptoms. We admit them for NSTEMI. And so we admit them for non-emergent cardiac catheterization plus or minus percutaneous intervention. And so here they are. What if we had a scenario in which there was actually ST elevation if we got an EKG at that time? And what if we had one after they were admitted, right? They're already admitted, we made our decisions, everyone's gone home, but there's ST elevation. And what if you look back at that first ECG and there were hyperacute T waves? The one after that reperfusion, there were Wellens type B T waves. Maybe at 6 hours, if you looked at the ECG, there were actually hyperacute T waves present again, right? And would your management change at that point? And so I ask you, do snapshots in time tell the whole story? And so imagine you have a scenario like this, from 6 a.m. to 12 a.m. You wake up in the morning and look, your power's out. You go to work and you get in a car accident. You finally get to work, and at work, your coffee spills on your clothes, on your computer. You can no longer use your computer. Well, not looking like a good day so far. Come 3 o'clock, you get a raise from your boss. Your boss also calls you and you get promoted. At 6 p.m., you find out that you're the employee of the year, and then you get a call from your wife as you're leaving that she's in labor and going to the hospital. Your power is working again, you have your first child, and you get a good night's sleep. Now, how would you rate that type of day from where it started to where it ended? And so when we look back at this patient's 6 hours, all of these are non-ST elevation patterns, right? At least not diagnostic for STEMI. These are all 10 seconds. And so 4 ECGs, 40 seconds, and that 40 seconds is in that 6 hour total evaluation time that the patient presented and we reviewed them. Well, let's take a look from 0 to 6 hours. If we blow this up a little more, that's 6 hours, which is 21,600 seconds. That's 40 seconds of ECG. So if you take the ECG evaluation time of 40 seconds over that 21,600 seconds, well, that's 0.185% of time. And so if you could see that little dot, that's the drawn to scale, and that's the ECG evaluation time. Okay, there it is. And so when you think of this STEMI versus NSTEMI labels we use, it depends on when the ECG is recorded. It depends on the presence of diagnostic ST elevation criteria, and the ST elevation can be subtle. And some ST elevation may not meet designated thresholds we've set, and some NSTEMI ECGs may represent similar underlying pathology to STEMI ECGs. And so are there other ways we should think about this? Has been questioned. And so I'm just going to kind of propose some of these things. Well, we should know that all ECG related ischemic features should be considered in the context for clinical decision making. If there's the presence and degree of myocardial injury, we have to factor that in. Is there evidence of a new perfusion deficit? You put an echo at bedside. Do you see a new wall motion abnormality? Is there active, incessant, or refractory symptoms the patient is having? Is there hemodynamic or electrical instability? Therapeutic and procedural risk and benefits also have to be factored in based on the patient. And so under ideal circumstances, any life-threatening intracoronary thrombi should go to reperfusion. And so when we think of this STEMI and STEMI dichotomy, a lot of people have kind of drawn this into caution where we know that every pathology has a spectrum and the same is true for AMI. And so we have to factor in multiple different things. With the standard STEMI, the amount and location of vulnerable myocardium matters. The degree of injury, is it an anterior versus inferior MI? Is it proximal versus distal? And STEMI, we think of type 1 being higher risk than acutely than type 2. The presence or absence or resolution of symptoms also matters. And so some have suggested this OMI or OMI-NOMI paradigm where non-occlusion MI, NOMI, NOMI, is no flow limiting coronary artery disease or adequate collateral circulation, and occlusion MI, OMI, near total coronary artery occlusion with inadequate collateral circulation. So you could think of it almost as a supply-demand mismatch, and maybe more of a type 1 MI where you have a plaque rupture and erosion, in this case, non-occlusive. But these patients are certainly candidates for reperfusion therapy. And so there's another way to think of it as the acute thrombotic occlusive spectrum, where you have these occlusive disease, plaque rupture. This would be non-occlusive. This would be occlusive disease. But both of these could present with patterns on the ECG of ST elevation and non-ST elevation patterns, right? Now, the one that's fully occluded, ST elevation, STEMI patterns are more common, but they both have trending troponins, transmural injuries more likely, and these are both considered type 1 MIs. And some could, here's another way to look at it, coronary flow, from on the left side, normal coronary flow to no coronary flow. Here's a normal coronary artery, here's atherosclerotic disease, kind of a supply-demand mismatch, and then you could have eventually chronic thrombotic occlusion, and then there's more of that acute phase occlusive disease from non-occlusive to this fully occlusive disease. But there's that spectrum of, remember that any in sort of ischemia is more of an active process. And so there's that constant inflammation that's going on, and you could go from occluded, fully occluded to non-occlusive disease back and forth. Okay, so kind of occluded to that reperfusion phase. And so I want to caution you of the STEMI and STEMI dichotomy because it's been reported over 25% of occlusion MIs are missed. It restricts us with our early decision-making if STEMI criteria is not met at a critical point in time. And as a result, our patients could sometimes receive suboptimal care, such as intervention later in the course, as we saw with our earlier example, and too late to rescue that ischemic or infarcted myocardium, and patients could have bad outcomes. Now, there's also the case where you have non-ischemic ST elevation, and these patients could undergo more catheterizations that are unnecessary, putting patients at increased procedural risk. And so solely relying on ST elevation is insufficient for determining who will and who will not benefit for emergent reperfusion therapy. So the second key point, as I mentioned, is acute MI is dynamic because the pathophysiology is dynamic, and therefore the ECG findings will be dynamic. Now, moving to part 3, this is where it gets fun. We start looking at subtle ischemic ECG features that you should recognize. And these are those that are not meeting the standard ST elevation diagnostic criteria. And so the third key point is that the 12-lead ECG cannot reliably distinguish between acute thrombotic occlusion and supply-demand ischemia. And so there's multiple ECG patterns on the ATO, the acute thrombotic occlusive spectrum, that do not fulfill the standard STEMI criteria. And the guidelines actually recognize this, right? If you have ST depression in V1 to V4, it's recognized as an ischemic pattern. Diffuse ST depression with ST elevation AVR, hyperacute T waves, these are all recognized by the guidelines. But what's the current state? Well, there's other ECG patterns that predict occlusive MI that are recognized by many in the field, but are not incorporated into diagnostic criteria. And many clinicians are unaware of such of these patterns and thus may be inappropriately reassured that there's no occlusive disease in the absence of diagnostic ST elevation. And so we know that ischemic T waves, hyperacute T waves are things we should look for. De Winter T waves that are present, Wellens T waves, right? And if we looked at back to our patient, we may have seen hyperacute T waves, the Wellens T waves and hyperacute T waves that would have changed how we manage that. And that's if you were able to recognize some of these subtle patterns. And so let's look at just the inferior leads and what is actually significant inferior ST elevation. And we'll group these into 3 different categories: normal inferior ST elevation, subtle inferior MI, and acute pericarditis. These tend to be the 3 we want to differentiate. And so when you think of normal inferior ST elevation, that's that early repolarization, now often referred to as normal variant ST elevation. And when you think of the subtle inferior MI, what I want you guys to leave with is that look for reciprocal ST depression in AVL, even if there's minimal ST depression in AVL, if there's less than 1 millimeter of inferior ST elevation, or even ST elevation in those left lateral precordial leads, V5 and V6, right? And I don't think you should assume that it's normal if you see any ST depression in AVL. So keep that in mind. Now, when you think of acute pericarditis, well, there should not be any ST depression in any lead except AVR, and sometimes you could see it in V1. And so if you look at this ECG here, which of the 3 is present? Well, just based on time, I'll let you know. So this one is actually a normal inferior ST elevation pattern. And so if you look here, you have this notching in the inferior and anterolateral leads. You could see that there. And that's sometimes referred to that fish hook sign that you can see, and this tends to be more of an early repolarization or normal variant pattern. If you look at this ECG here, well, this one is actually acute pericarditis. And if you look at AVR, you're seeing the ST depression. Throughout, you see ST elevation almost diffusely, but notice there's no ST depression in AVL. And there's also this pattern here where if you look at V6 and you take the ST elevation to T wave amplitude ratio and it's more than 25%, that suggests acute pericarditis. You know, I was really convinced by that, but I got an ECG the other day and it was an occlusive disease. So now I'm a little cautionary based on that finding, but that is one to keep in mind as well. It's kind of using all these, adding them to your toolbox as you approach an ECG. And so here's another ECG, right? Is this normal ST elevation or not in the inferior leads? So if we look here, what you see are hyperacute T waves actually throughout the inferior leads, 2, 3, and AVF, and as well as that T wave inversion, that reciprocal change in AVL. And this was actually an acute right coronary artery occlusion. And so the big takeaway from this is that T waves in this case are not large by themselves, but in relation to the QRS component, that amplitude, they are. And so the big takeaway is proportionality matters. Okay, so make sure you're looking at the proportionality of the T waves to that of the QRS amplitude. How about this one? Here's another example. You have your inferior leads. Is this normal or not? Well, if we take a closer look, there is some subtle ST elevation in that inferior leads, and there's some subtle ST depression there in AVL. This was another acute right coronary artery occlusion. And the takeaway here was, again, the ST depression. If you see that in AVL, right, and you see ST elevation in the other inferior leads, make sure that you're not missing an inferior MI. And so when do you suspect an inferior MI? Well, patient presents with ischemic symptoms and findings on the ECG of, say, a normal QRS, inferior ST elevation, and then any ST depression in AVL, especially with T wave inversion. So keep that ST depression AVL in mind as you look. Now, let's look at anterior ST elevation. When is it normal and not? Because this can get confused. Many left anterior descending occlusions are missed at initial presentations because they're thought to be normal variant ST elevation. And so because of this, many are not diagnosed until they rule in based on troponins or the cardiac biomarkers you use. And then they go to the cath lab, the coronary artery is open, that's great, but the damage is already done. And so the final diagnosis, what do you think they give them? NSTEMI, right? So despite that occluded artery and it was reperfused, it's didn't meet the STEMI criteria, so the patient leaves with an NSTEMI. So how do we differentiate normal variant ST elevation from acute LAD occlusion? Well, I've put together this table here and all the features on the left, and then you have the normal variant ST elevation, and on the right, anterior MI. So the first one is abnormal precordial R wave progression. If you see that, that should be a sign of anterior MI, right? And these are findings that are subtle outside of the obvious, huge ST elevations that you could see with an anterior STEMI. So these are more of the subtle characteristics. So abnormal precordial R wave progression, we look at that by diminished R wave or Q waves in V2 to V4. If you take the R wave amplitude, that composite, the summation of that in V2 to V4, and it's less than 15, that's considered diminished. Or if any of those leads, it's less than 5 millimeters. The late or absent precordial R wave transition. If you see a J wave or well-formed S wave in V2 to V3, that would suggest oftentimes more of a normal variant ST elevation, whereas terminal QRS distortion in V2 to V3 would be more of an anterior MI. And we define terminal QRS distortion as the absence or loss of J waves or S waves in V2 or V3. So if you look here, look at V3 there, you see that loss of the S wave is not there. And so this would be a sign of more of a terminal QRS distortion. Any Q wave in V2 to V6 suggests more of an anterior MI. So any Q'd out waves in those precordial leads, think about that. Any reciprocal ST depression on the ECG should point you to more of an anterior MI than that normal variant in the anterior leads. Straight or convex ST elevation in those precordial leads, also think about that. Concave ST elevation, well, that tends to be more of a normal variant, but you can't always rule that out. And that's why the clinical context is always important in assessing the ECG. Now, very high voltage ST elevation, like that common pattern, almost like a tombstone, think of more of the anterior MI. Abnormal T waves in the precordial leads, again, favoring anterior MI. In abnormal T waves, well, what you want to think about are symmetric, wide-based, and you have the T waves that are out of proportion to the QRS. So that think of the T wave towering over that R wave, and then T wave inversion in V2 to V6. Okay, and now there are some benign variants of T wave inversion that you should be know about, but if you're not sure, again, you don't want to miss a large infarct. Okay, so if you're not trained on identifying them, I would be caution of calling it benign. And then U waves, actually, you can often see these actually with normal variant. We tend to think of U waves with, say, hypokalemia, but there are some cases with normal variant U waves in those leads. And then using the QTC as the cutoff, a shorter QTC, which is considered an average of 390 milliseconds, is more normal, but a longer one with the average of 420 milliseconds tends to favor more of a serious thing. Okay, so is this normal or not? You have V2 to V4. If we look at this closer, this was actually a normal variant. So why is that the case? Well, now you're seeing, as we saw, S waves that are in V2 and V3, so there's no terminal QRS distortion. You have that high voltage R wave in V4, and you have actually short QTC. This one was 370 milliseconds. Remember that normal average QTC was 390, so it's within that. So those are some things. Again, only focusing on anterior ST elevation. So is this normal or not? Okay. So here you have this ECG here. Well, in this case, if we look, this was actually an occlusive disease. So if you look at poor precordial R wave progression, you can see that from V1 to V5. There's that low R wave voltage in V4. And then you have actually QTC was long, measured at 420. Remember that ischemic average was around 420. So these are just other features, and many have proposed different ways we could do this in cutoffs. And I would be amiss if not to mention Dr. Smith and his work in working to differentiate this. Now, here's another example of it where you have, is this normal or ST elevation, right? Is that benign ST elevation you see in V2? Well, if it is benign, we should expect normal precordial R wave progression. Do we see that here? Well, we don't. We have a small R wave in V4. If we look and we expect benign ST elevation, we should expect asymmetric T waves. If we look here, we don't see that. Those T waves in those anterior leads look symmetric, and they just look tall, and they're, remember, towering over that QRS. So not normal here. And then we have another ECG performed just a little while later. And what you could see here is this ST elevation evolves into a true STEMI. So if I compare them side by side, you can see now, look at V2 to V2 on both sides, the ST elevation and all these has now made itself present. And the patient was, the cath lab was activated, and this patient had 100% mid-LED occlusion. So the post-cath ECG showed this, and what you see is normal ST elevation now in those leads, and T waves in V2 to V4, and some T wave inversion in those left lateral precordial leads, V5 and V6. And so here's the presenting ECG sequence, the repeat ECG that activated the cath lab, and what you could see, and here's the post-cath ECG. The first two, look at that ST elevation, how it evolves over time, and then after reperfusion, you could see how that goes back to normal, and you have that T wave inversion in those V5 and V6. So the learning points here is you want to make sure you're explaining all ST elevation as you look at an ECG, even if it appears benign. Early recognition might save myocardium and maybe a life, and these patterns can be learned. And so the third key point is that the 12-lead ECG cannot reliably distinguish between acute thrombotic occlusion and supply-demand ischemia. So to end part 4, these are the non-ischemic STEMI mimickers. So the fourth key point is simply to be aware of these non-ischemic STEMI mimickers. And so when we think of STEMI mimickers, what that means is ST elevation resembling a STEMI, but from a non-ischemic condition. So non-ischemic ST elevations, these are actually common patterns we can see. And most patients that have undifferentiated chest pain and they present with ST elevation of 1 millimeter greater is not a STEMI. And so these are some of those mimickers. Here's normal variant ST elevation. Here's left ventricular hypertrophy. You can see the elevation, but not a STEMI. Pericarditis, another mimicker. Brugada type 1. Takotsubo. I mean, if you see that, you'd probably take them, but you know, there's a few other things you should consider. And left bundle branch block. So you want to be aware of these different patterns, because if you have non-ischemic ST elevation, well, what could happen is false activation of the cath lab. And here's one from 2007, a JAMA study looking at false positive cardiac catheterization lab activations among patients that had suspected STEMI. They took 1,300 patients with suspected STEMI, and there was found a 14% false positive rate, meaning that 14% did not have any culprit vessel that was involved. And so what they thought, and they concluded, at least proposed, was the false positive activations was maybe due to non-ischemic STEMI mimickers. So how do we decrease that rate to decrease the false activation? Well, I think ECG education, everything we're doing today and that you're getting from these experts is important, because you have to learn these patterns. Oftentimes the activation is based on those first responders, those on the front line. You don't always have an electrophysiologist, a cardiologist to make the decision. Okay, so we have to be better at educating those on the front line. And so the fourth key point here is that we want to be aware of these non-ischemic STEMI mimickers. All right, so we looked at part one, the ECG and ACS, the STEMI and STEMI dichotomy in part two. Part three was the subtle ischemic features that you should be aware of. Remember the inferior and anterior ST elevation. And part four, non-ischemic STEMI mimickers. And so final key points to take away from this today is that many patients with ACS do not manifest any signs of ischemia on the ECG. Point two is that acute MI is dynamic because the pathophysiology is dynamic, and therefore the ECG findings will be dynamic. The third point, the 12-lead ECG cannot reliably distinguish between acute thrombotic occlusion and supply-demand ischemia. And lastly, be aware of those non-ischemic STEMI mimickers. You want to keep those in mind. So thank you for everyone that listened. Hopefully it was probably faster than you'd like, but hopefully that was helpful. And again, it's been a true pleasure, and I'm happy to take any questions. Thank you.
Thanks a lot, Anthony. So let's see, what do we have in the chat? Do we have any questions? Anthony, it was a great talk. It was absolutely great talk, and you know, I have a couple of questions to you.
Sure.
Out of all criteria you kind of proposed and highlighted, would a degree, for example, of diminishing of ST depression in inferior leads versus lead 2 play any role in, you know, recognizing pseudo-ischemic or ischemic patterns?
Yeah, so if I heard that correctly, was it ST depression or ST elevation?
Sorry, ST elevation. I
Okay,
meant
yep.
was ST elevation.
Sure. Yeah. You know, again, that was the key thing of looking and trying to characterize, is inferior ST elevation important? Is it significant or not? Well, you know, we know that some of those variant patterns, especially lead 3, can show some, you know, elevation. But yes, if you see probably lead 2 greater than lead 3, then that would probably be an ischemic sign. We know that even with some other acute conditions, acute PE can sometimes present with that, maybe from the right ventricular forces. But yeah, I think lead 2 would probably catch my eye more if I saw that elevated, especially greater than lead 3. What are your thoughts?
You know, I don't have any kind of strong factual based data on that. But I would say that any kind of unusual dynamic between lead 3 and lead 2 would be red light.
Sure.
In other words, typically lead 2 is a mix or somewhere midway between lead 1 and lead 3, right? So if you think about reciprocities, then I would assume that in ischemic events with, you know, subtle forces toward ST depression in left-sided lead, actually lead 2 may have less ST elevation. Thanks. Here's a question from Radhika. Radhika, you want to sound it?
Yeah, sure. That was very interesting, and I wonder about the sensitivity and specificity of some of the findings that you highlighted. But I was also wondering about the use of AI or some form of machine learning to actually help improve the ability of us being able to detect these with more accuracy.
Yes, that's a fabulous question. And again, I think the sensitivity and specificity, you know, we have this available, but it's hard because we don't really know a lot and study much of these non-specific features because, you know, they're not within the guidelines. So I think it's just kind of keeping that in mind. With regard to machine learning, we're actually taking that on here with the ischemia. The tough thing with that is choosing which ECG to use, right? Because we know this is a dynamic process, it's not really, we all know that machine learning could help us do that. But it's really which cohort do you use? And then also which ECG do you pick? Because patients may present with ECG1 and look normal. So you're using that as your model builder, but then ECG2 is actually the one with the findings that activated maybe a cath lab. And so you don't always know which one to choose. And what's important is that for any AI, at least deep learning model, you need a lot of data, right? And so because you're not really using any rule-based algorithms like we used with computerized interpretation, you're depending on a model to learn these patterns, these subtle features. And so part of the problem is, I think everyone sees the value in ischemia in detecting it, especially the dynamic changes, but it's the issue of choosing what is the right group to use for this in the right ECG. But I think that's the future.
Okay.
So, I mean, as we move on to beat, detection of things, we may be able to do more. Sorry.
Yeah, more
Eugene,
than
before you introduce the next, I just wanted to remind everybody it's Wear Red Day in Canada. I actually didn't wear red, but I have a red scarf on now, and in honor of women's heart disease. So just a shout out to Heart and Stroke and Wear Red. All right, I have the distinct pleasure of introducing our next speaker, Dr. David Newman. I actually met Dr. Newman over 2 decades ago, because Eugene just reminded me he's been at Sunnybrook for 2 decades, but I met him as a cardiology resident when he was at St. Mike's, and it was an absolute pleasure learning and working with him, and I'll never forget the time I was able to spend with him. And so I'm lucky to be able to spend winter arrhythmia with him every year, because he's here. And he is currently at Sunnybrook and is still working away, which is awesome to see. He's also a native Haligonian, and he grew up in my neighborhood, which I live in now in Halifax. So great to have you, David. Graduate from Dalhousie University, and I'll let you go.
Thank you so much. First of all, thank you so much to the organizers of this, to Dr. Prakash and Dr. Crystal and the speakers. And I've got the interesting task of trying to talk a little bit about where Holter monitors are, where they're going, and how they interact with our smartphones that we're now plagued with by our patients. Some disclosures. I'm going to talk about what options are now available. I'm going to focus on some newer technologies for Holters that we are all aware of. And I really want to spend a bit of time on smartphones and technologies, a little bit of history. This is Norman Holter himself. What many people may not know is the first ever clinical, as opposed to engineering, paper by about the work he was doing. This is 1947 with a 50-kilo Holter, and that's the image from it. It was actually published in the Canadian Medical Association Journal in 1954. And the conclusion was this stuff will have no clinical advantage. What a great example of our inability to predict the future. And of course, here we are only about 10 years later, 1962. This is a woman wearing a 3-kilo Holter, went from 47 kilos to 3 kilos. In the back is a 57 Edsel. Notice these beautiful white leather gloves. Here she is eating in a restaurant. This is Holter himself. In his pocket is an aerial coming up almost to his ear. And behind him is a trunk that he brought to the restaurant as a proof of concept that this can transmit to that. And he then published a mechanism for analysis. Remarkable stuff. I'm not going to review this at length. An audience of this nature knows that Holters have lots of indications. The main, if you wish, sine qua non of a Holter is to make a connection between a symptom and a rhythm. And that is what it's all about. The symptom can be palpitations, or we can doing it prior to therapy. We can use it to assess therapy. And of course, time for device therapy, I'm not going to talk much about. The other value of a Holter is VPB counting. And in fact, that is how Holters began, with the Mr. Fit trial of 40 years ago or 50 years ago. And in fact, that led to the whole VPB hypothesis that finally got denigrated in the CAST trials. And in fact, VPB counting as a role for Holters is now actually more modest. VPB counting still has a role for heart block or ablation. Those of us who do ablations for VPBs need a Holter pre and post. The real interesting topic, of course, is Holters in AFib. And the issue, of course, is the prediction of AFib which is APB counting, or the detection of AFib, which I'm going to spend some time on. Holters for assessing medications are there. That's a rare bird. Holters for channelopathy are very important for dynamic changes, probably the really pure indication for 12-lead Holters, which are very rarely used. And then there's ischemia monitoring, not that valuable because of the variations that you just heard from the previous talk. And as a research niche, Holters for heart rate variability and turbulence, I'm not going to talk about. The on the right, you have a conventional Holter, standard multi-lead Holter. And on the left, you have one of the new patch electrode Holters. And obviously, you can see the massive difference in hardware convenience and the remarkable advances in technology that allow Holters to be very, very small. This particular one is an Essentia device. Here is one good study out of Montreal looking at the Holter using standard Holter, the previous one on the right side, same patients looking at the Essentia patch electrode Holter. It's a one lead. And again, as you can see, no real difference in any of the measures that count, but a slight increase in the amount of noise makes sense because one is a single lead. I'll argue that may not matter clinically, but we'll come to some data to show that. And other than that, really no huge difference on any clinical variant that counts. Here's just one comment on noise. We're clinicians, and clinicians are good at seeing noise. So although there's a lot of air talking about single lead versus 3 leads versus multiple leads, at the end of the day, we're pretty good at calling that noise. Although in this case, the machine called it AFib. Here's another one where the machine called it AFib, but it's really more likely there's atrial activity at various leads, and it's more likely some atrial tach. And here's another one where it called it AFib, clearly just getting fooled by ectopy. So noise versus not noise requires a clinical decision, and one that we're able to do. This is just an example of some of the patch Holter electrodes that are now available. This is a 3-lead device. I've had limited experience with that. The patch electrodes for 1-lead devices are the Canadian out of Quebec Cardiostat. This is an American device called a Zeo patch, the first one, by the way, that ever came about. This is Gus Barty's device called the Carnation. In fact, I have discovered, and we've published, that this actually device is probably better in a vertical orientation. These are the 3 patch electrodes that are now available. There may be more. I've used at least these ones. Here again is an example of this Essentia Holter. And I just want to make this point that all these Holter talks, they always show these extremely buff torsos with very cleanly applied electrodes. But the reality is, of course, people that are very different. Here's an example of one. This is the actual device. By the way, you can see that there's an electrode. There's a collar put around the electrode. The device has a button in the middle for someone to press. In this particular case, an extremely demented woman, the device was put in an interscapular position so she couldn't tear it off. This may have a role for children too, by the way. And her problem was syncope, and her caregiver was instructed to press the button whenever a syncopal event occurred. And indeed, we see here an episode of syncope. You can see the irregularity of rhythm. She has continuous atrial fibrillation. And when the device was pressed during a syncopal episode, she continued in atrial fibrillation with no real substantial change in heart rate. And indeed, she got anti-seizure medications and stopped fainting. And it was, in retrospect, a seizure disorder in an elderly woman with brain pathology. The newer ones, at least some of the ones I've been using, the Essentia one, also seems to be, although they don't say this, waterproof. Here's an athlete who had symptoms while swimming. And again, we were able to pick up with reasonable, good, clear signals, a run of a non-sustained atrial tachycardia. And here's a remarkable case, a woman who was in a hot tub, and a squirrel. She had atrial fibrillation that was permanent, but she refused all therapies. And over time, her EF was falling, and she still had no symptoms and said, "Leave me alone." And then a squirrel jumped into her hot tub. She produced 10 pages of a diary, but a squirrel jumped into hot tub, screamed, swift water, tossing its squirrel, did not feel my heart race, but boy, did it race. Look at the peak that the heart rate went to here. The arrow is her device activation. She went to a heart rate of 190 to 200. And when faced with that, she was very keen to ultimately get something done. So just an example of this technology. We've taken this one step further, and we've used, given how simple it is, we asked the question, could this be done as an entire mail order experience? And we decided in conjunction with a stroke clinic group in the hospital to take 50 patients who had one of these devices, and we compared it to 50 patients who simply had the device mailed out to them. And the people who had the mail out device got the machine, they got a URL that they could look at, they got instructions on how to do this. And what we found is no difference at all on the magnitude of noise, on the hours recorded. We did find that one patient had a wrong address. One patient was unaware they were even getting this device, but certainly the ability to do a mail out Holter with these kinds of technologies is now here and is something I think that can be available more widely. In the end, we have a few days to order it. From the time it was shipped to the time it was returned was 30 days, even though it's a 2-week device. So obviously, people may get this machine, but they may not return it. And there needs to be efforts from a quality analysis or control viewpoint to make sure you get your device back. How many leads does the monitor need? Well, clearly, all that I showed you at the beginning in terms of the indication for a Holter are all based on one lead recording. The only places where multi-leads really are critical is going to be channelopathy and arguably ischemia monitoring. OHIP in Ontario, I don't know how many of the audience are in Ontario, doesn't agree with that. OHIP said that if you're doing only one lead, that should be costing less effort than multiple leads, and they charged a different fee code, although that's not clinically based and of course isn't based on any data. I want to just quickly talk about now AFib. So the Holter in atrial fibrillation is got only really 2 roles. One is to look at heart rate in atrial fib, and the other is to detect AFib, and the third is to predict AFib. Here's just a simple example of a heart rate in AFib and the heart rate profile that you can see the patient has. Very useful to look at nocturnal heart rates. This is not a talk about atrial fibrillation management. The RACE trials out of Holland are very important. And the CCS Consensus Conference on AFib Management says your goal is an average heart rate less than 90, and the percentage or over 100 should not be a large amount. Clearly, what count are symptoms more than rate, and I would argue, although not talked about, LV function, and in particular, LV cavitary dimensions when assessing rate in atrial fibrillation. A heart that goes fast will have a low EF, that is expected. And a rate-related myopathy should also include some sense of cavitary dimension change. The real topic, though, is can we predict AFib? And here is a variety of papers looking at APB burden as a predictor of atrial fibrillation. And there's different numbers touted. This is David Gladstone's excellent work at Sunnybrook Hospital, where patients, now these are a high-risk group, they all had a cryptogenic stroke. And this group who have a cryptogenic stroke, what proportion of them actually have AFib as a culprit? And it's critical in terms of their management for preventing recurrent stroke. And what they found when they had a 30-day recording is there is a 15% incidence of AFib in these patients. We all know from the ILR research literature that that number goes up the longer you record. What's very interesting is they found that only 20 APBs per hour on average, or 500 per day, seem to have an important role at predicting AFib. And the other thing, of course, was most of the pickup was within the first 2 weeks of the AFib. So this idea of screening for AFib is where we're at now, and that's where the watch comes in, which I'll talk about in a moment. And it's very important to realize how controversial this is because of all kinds of challenges. Some feel that you should be screening. Here's a very controversial editorial that's saying if you see lots of atrial ectopy, and you have patients at risk, then you should consider this patient as someone who is suspected AFib. Be prepared to give them antithrombotic therapy. The hook is this. This is the ECGs trial out of Hamilton. Excellent. And what it showed is that you cannot suspect AFib, you have to prove it. Because when they took a group of patients who had an embolic stroke of undetermined source, so their neurology adjudicated to have had an embolic infarction, these 7,000 patients were randomized between rivaroxaban and aspirin, and it's the only negative antithrombotic trial, other than a very small one on hypercoagulable states in cancer. So in other words, they got low-dose Rivar versus aspirin, and they all had no carotid disease. They did not have lacunar events, and they were all over 50. And lo and behold, no difference in outcome for recurrent stroke, but a difference in bleed in favor of aspirin. So the message is we cannot presume AFib. I think we have to prove AFib, which means a Holter or some device to monitor is going to be needed. This led to the controversial American recommendations. This is in August of 2018. Evidence is not there to support the balance of mass screening for AFib. The reason it's a hot topic, of course, is silent atrial fibrillation is there. And most of all, this is an old study from 2014. It's an anticoagulation trial, but the message is that if you have patients who need antithrombotic therapy, it turns out that the adequacy of their antithrombotic therapy, in those days, time in the therapeutic range, had a correlation with the onset of dementia. So the hot topic, of course, is to predict those who need antithrombotic therapy. And now ECGs tells us you got to prove it on the ECG as a tool to prevent the development of dementia. And that's the topic of the day that we don't know a lot about. Here's the European guidelines on atrial fibrillation screening. And of course, opportunistic screening, taking a pulse, that's easy to recommend. There's a lot of verbiage. The bottom line is this one: systematic ECG screening by patient-owned device or Holter or any other technique is something that should be maybe considered if they're older. And that's the controversy right now, and it's different than the US guidelines. And the Europeans were very influenced by Martin Rosenqvist's study from Stockholm, where they took a complete population in an area in Stockholm, and they were able, in Sweden, I should say, and they were able to screen an entire cohort of patients who were over 75, and they were randomized to an ECG screen or male, and the ECG screen was 2 times a day for 30 seconds for 2 weeks, and new AFib in 3%. And then this is a Canadian study. Many of you perhaps were a part of it, using the Isentia device in 1,000 patients. And again, a 2.7% pickup for AFib. And this was a group who were 65 or older and had other risks. So screening's coming. Here's the European statement on what's available. There's 100,000 apps, 400 wearable devices. And the real issue is those who have irregularity detection versus actually recording an ECG, automatic recording versus patient-initiated, and whether it's a standalone device or part of a phone that can also do other things. They all, in my view, are going to require some kind of ECG review. Whether they always need a Holter is a different topic, and whether other markers are going to be useful. In terms of what we have in Canada, the big three are Fitbit, AliveCor, and CardiBeats. This is an irregularity detector, just simply showing a happy face or a sad face for AFib or no AFib. Here is a low-tech irregularity detector, which is taking the pulse. This is from 1790. Look at this beautiful picture of this man taking a woman's pulse. Notice that he's actually measuring her ulnar pulse, which is not the way it should be done. Even more interesting, look what he's looking at. It ain't her pulse or anything else. And she's like, it looks as though the two of them have a rather interesting gaze towards each other that has very little to do with holding a hand, or maybe a lot to do with holding a hand. I'll skip that. In terms of the European guidelines and what they say, pulse taking has a certain sensitivity and specificity, and the sensitivity for the watch, which I'll come to now, is very high, with the specificity, of course, which is low, false positive. Here's what's available, kind of, and these are recording an ECG on someone's home. The original ones were handheld ECG devices. The heart check pen I have used, this is the original version of it. This is a smaller version of it, a dedicated device for the patient to record their own ECG. The newest ones are the smartphone-enabled apps. The Alive Core is the first one that was used extensively. The patient holds it, it produces an ECG. Cardi Beats is another company. I used to work on them. I don't work for them as much now. Again, they have a credit card type device that the patient holds with two thumbs and records an ECG. Both of these are patient activated for symptoms. The Fitbit, newest version, there's many versions of the Fitbit, records an ECG again. It's kind of like the Apple Watch, but it doesn't tell the time. It just records an ECG and doesn't have other functions. And here's just one example. This is a very unusual case. It's an Alive Core recording using the same patient exactly. And it's just the same exact device. One is a Alive Core, one is a heart check pen. And it's just showing the effect of filtering. This is the same signal. And this is a modified lead 1 and modified lead 2, if you want to be technical, for Dr. Baranchuk. And you can see that there's a lot of noise on this signal, not seen here. Personally, I'm like to see noise because I'm better at seeing signal through noise than having an algorithm remove noise, and at the same time with the smoothing, sometimes remove low frequency components such as a P wave. This is the Apple Watch. So I told you 2018 comes the US guidelines that screening shouldn't be done. And then 2 months later in Cupertino comes the announcement at their conference of the Apple Watch. And this is an ad that has since been withdrawn from their circulation. And the image, of course, is this is a health monitor. Whoops, I'm going to go back if I may. A health monitor. And they have a model, I presume, a professional dancer wearing a body stocking, and there's no curve in the human body that's not illustrated in this picture. And it ends at her wrist with part guardian, part guru. And it feeds, of course, into the neurosis of young, healthy people who want to monitor themselves. The reality, of course, is this kind of guy. And he is the person who really is at the risk for AFib. And she is the one who's modeling their beautiful phone. And of course, the watch has these messages. Your heart has shown signs of an irregular rhythm suggestive of AFib. Please see your doctor. And in my experience, what the patient reads or hears is you're about to die. Be prepared to say goodbye to all you love and cherish, and is your will in order. And all of us, I'm sure, have seen patients with the message on the right of what they understand compared to the message on the left, which is what's written. Here's a great example I had from just a few weeks ago. The patient has a new Apple Watch recorded January 30, so 2 weeks ago, just in time for this meeting. And he has a new watch, and he decided to show it to his sister, really just saying, I have a new toy, completely asymptomatic, and was surprised to see, oh my, it says I have atrial fibrillation. So an asymptomatic AFib in a 50-year-old with a watch. The other extreme, of course, is this one. Again, this is a watch diagnosis labeled as AFib. I think this may be a Fitbit. And here is, in fact, what the patient really has simultaneously, atrial ectopy. So the watch has been subjected to excellent, good work. And this is the famous Apple Watch trial, the smartwatch trial. And what they did is they gave this thing to 400,000 people. And then if there is an irregularity notification, they got a follow-up Zio patch. That's the electrode I showed you. That's the patch electrode. 20% got that. And what they found, of course, is 0.5% had irregularity notification. And therein lies the rub, because only 20% actually got the validation with the Holter. And the sensitivity and the specificity is the challenge. They published another paper showing about the 200 of these patients, these 41,000 patients, an irregularity pulse notice came out to 2,000. 400 of these, 450 got an ECG patch, of whom 297 had no AFib. but they did have lots of other arrhythmias. Atrial ectopy was seen in 80%, ventricular ectopy, non-sustained VT, and 30% of those who had no AFib detected went on to have AFib. This is the AFib prediction stuff I was talking about. So this means, of course, that the Apple Heart study is very important. It's critical, but it's not going to help us as much as we may want. And it's going to produce a storm of patients coming to us that we're going to have to figure out quite what to do. It's a very nice paper from Heart Rhythm on the legal and ethical issues surrounding it. And I would star these two parts. There's a false positive part, and then there are litigation risks. Who's responsible for notifying who when a device like this picks something up? And my patient, for example, what does one do when it's totally asymptomatic? The other challenge with these technologies is the opportunity to engender lots of neurosis. Here's a healthy 35-year-old who has nocturnal heart rate slowing, and the message he got is his heart rate is critically low and he's going to die. And that's the kind of messages that we're getting. Here's another patient. This is using an older device that records the ECG using a heart check pen type device. And here, 50 pages of records, because he pressed and activated and recorded every single VPB that he had. And he had lots of VPBs. Here's one, and it has a small restrictive VSD, and the neurosis engendered is huge. On the other hand, this is a Fitbit. And this patient has paroxysmal AFib, as you can see here on his Holter. Fortuitously, he had his paroxysmal AFib while activating his Fitbit, and certainly showing beautiful example of how the ECG indeed can record AFib, and of course, in this case, correlated with the Holter. And now, just to make matters more intriguing, coming really down the road quickly is further uses for these technologies. This is out of a group in Italy, and they're collaborating very much with the group at Brigham in Boston, looking at the QT, putting the device over the skin in different areas and doing a nice Altman blend plot of the QT analysis. So it's coming quickly. And just to finish off, it's going to get worse before it gets better. This is woven technology. These are now wearable technologies inside clothing. So this is wearable measurements and smart clothing to record a really beautiful ECG in a textile. And lastly, not really my topic, but it's impossible not to mention, I think, the paper of the year, where you have the ability, forget trying to predict AFib from APBs. You can predict AFib just from an ECG. Pittsburgh group, 1.6 million ECGs. And what they did is it's AI deep learning approach using a neural network technology, and it's totally agnostic to anything in the ECG. It's measuring all kinds of things we may not even see. And what they found is an ECG can predict stroke actually very, very well when they interacted this to a stroke registry. So my message really is these patient-owned recording tools are here. They're going to have an important role. They're always going to need a Holter to correlate or support, but these big advances in Holters may make that easier to do. And they're going to be valuable, these machines, for therapy and drug. The real issue for us is going to be deciding on the balance between patient sense of autonomy and neurosis that can be generated. And lastly, of course, the cost of these things and the disparity in healthcare access that there may engender. And that's it for myself right now. I'll take any questions.
Yeah, Dr. Newman, we're open for questions. We have quite a number here on the chat. Let's just start back. Eduardo Sanueza had a question. So when we compared ILR, Holters, and smartwatches, which one has better specificity for atrial fibrillation diagnoses?
ILR, Holter, and smartwatch. Well, obviously, there's no good study that's looked at all three together. ILR, and they all depend, I suppose, in terms of the issues surrounding the specificity. The issue will depend on the number of leads that you have. They're all going to be, if you're looking only at single lead systems, as long as it's read by a doctor who can look for noise versus signal, and it depends a bit on the filtering, I would think they would be somewhat equivalent. Holters that have more than one lead obviously may be superior. The gold standard is the key, I think, is capturing it on paper. Irregularity detectors are out. And the Apple Watch trial did mail out a Holter, a single lead Holter. Remember, a Holter is going to be capturing passively all the data, whereas a watch is only capturing a snippet of data, generally patient activated. So when you have a larger volume of data, you get more background noise. So clearly Holter is going to be superior. An ILR obviously is a gold standard, but it's hard. It's going to be very expensive to even remotely think of that having generalizable use. An ELR, an external loop recorder, clearly is useful, but there the issue is it requires a patient's symptom to be activated. So its value is on the specificity of symptoms, not on the detection of AFib. And in fact, when we used ELRs in my group for AFib detection, they quickly saturated with noise. And so I hope that answers your question. The watch clearly has got a huge role. Where it fits, unclear, is the simple answer. I see a question posted here, though, that I can ask. I think it's
there's
from...
a couple. Yeah, there's...
Sure. How do we improve the interface between patient recording and doctor validating the finding? Great question, of course, and thank you, Adrian, for that question. It's probably at the actual nexus of this whole problem. Patient comes to you with the recording. Now, what do I do? And of course, you may be recording a Holter afterwards, but not capturing what was there when the patient had it. Very complicated question, as we know. Antithrombotic decisions are key to this one as well. How much AFib do you need to warrant a concern for stroke prevention therapies? And we have 3 trials going on, as you know, with silent AFib and devices to help answer that. And right now,
my clinical problem, David, is the patient comes to the visit. It's scheduled for a 15-minute visit.
Right.
And he says, I have systematically collected information, transform it into PDFs. Would you please take a look? So I grab it. I have 200 pages, as you clearly shown, right? And while I'm passing the things and seeing noise, I'm thinking, what part of the visit am I going to sacrifice in order to see these 200 pages? Is it the physical exam? It could be. Is it me interrogating about classic risk factors for stroke? Am I going to be able to determine what is the CHA2DS2-VASc score? And I keep looking at pages and pages, because if I don't see every page and I return the phone to the individual is mad at me.
Right.
He's not mad if I don't use the stethoscope, but he's mad if I don't see the pages. That is what I call interface, and I would like you and the rest of the experts take on this. What do we do?
It's no easy answer. Obviously, it gets worse, because what if there's AFib there, but you missed it in your perusal? So I don't pretend to have an easy answer for such a difficult question right at the interface of what we're doing. First of all, I ask the patients to print, and if they don't print, that's their waste of paper. I know that, but that makes it much easier for me. Secondly, I will give a Holter almost always to these patients, because I'm using it to look at background noise, atrial ectopy especially, and nature of sinus node function and so forth. And also I'm using it to get a sense of this issue of APB burden and non-sustained AT burden, which may help predict AFib. And of course, the echo will help for left atrial dimension and risks and so forth. At the end of the day, though, I'm as stuck as you are. I look at the data. If it's AFib and I see that like my patient I showed you very nicely, a clean case of AFib, that's easy. The great majority are not like that. And that's where we are left stuck. And the noise saturation in young neurotics is going to be very difficult. And who pays for the visit? Who pays for the data? Who's doing what? Even OHIP billing for reviewing all of this, it's all over the place. So the simple answer to your question is I try to look at the data by having it printed. I usually will get a Holter and other clinical heuristics that will identify my risk of AFib. And to the best I can, I'll tell the patient, I don't have time to look at all of this, but what I see here is X. And beyond that, we're stuck. As we both know, yes.
Yeah, very difficult to manage the patient expectations. I think a heart rhythm is going to change dramatically as these monitors they're already out there, but even more so. So these are great things to be able to discuss. We probably need longer time to really come up with some answers and so on.
Okay, should we move to next presentation? My only comment to everything what David showed is that I was actually surprised how little I was, seeing that challenge in my practice. I probably see patients bringing tracings every week, but not in a huge amount. Anyway, we'll move forward with Ratika Farkas. Ratika is professor at Dalhousie, and she is very prolific electrophysiology researcher at Canada scale and at the world scale. Ratika will be speaking on remote monitoring of cardiac implantable electronic devices. Please, Ratika.
Thank you so much, Eugene. I'll try to make up some time so that we can end on time and have a little time for questions. So very pleased to speak about remote monitoring of CIEDs in Canada. I think the progression of talks that we've had today, we started with the good old ECG, which we will never let go of, with Dr. Baranchuk and Dr. Cashew, and then moving into where we are now. And then hopefully this talk will take us into where we're going in the future. We've already touched on that, discussing AI and machine learning and deep neural networks with respect to ECG and how it might help us. So just some objectives. We'll just touch on the current guidelines on remote monitoring of devices. We'll talk about how remote monitoring has evolved, and a little bit about the clinical burden and medical, legal, privacy, and cybersecurity issues with respect to these technologies. So this is just a review of remote monitoring technology. I think everybody is aware of how this works, but we have the patient who has the device implanted. They are able to communicate with a type of remote transmitter, which then feeds either over a phone line, cellular network, over Wi-Fi to a central database. And then that feeds back to the physician. The feedback loop to the patient is the part that has been a little bit in question. We do not have remote programming in effect at the moment, and there's various reasons for that. We'll touch on that shortly. In fact, when you talk to the device manufacturers, the technology to do remote programming is already there, but it has not been released due to some of the issues we'll touch on in this talk. And then the transmission feedback loop is variable across Canada. We've done a lot of work in this area to try to sort out how the transmission feedback loop actually occurs between the remote transmission and the patient. So all of our currently known manufacturers have some type of remote monitoring. I've just summarized them for you here. Biotronic has home monitoring using a phone line currently. It's called home monitoring. Boston Scientific has the Latitude system, which operates over a phone line, cellular, wired, or wireless internet, and can provide information over email, SMS, text, or website. Medtronic has this similar and now has a mobile app that they have called My CareLink Smart for patients, and has reduced the amount of money required to fund wireless monitoring, in fact, with the app introduction. Sorin has their monitoring system called SmartView, done over a phone line, and again, communication back to the provider using fax, email, or SMS text. And of course, Abbott has Merlin.net, capable of transmitting information over the phone line, cellular, and Ethernet, and then back to the provider, again, using those three options. So our current guidelines, just to review, were put together back in 2013. This was a position statement that looked at the use of remote monitoring in ICDs in particular. And the recommendations at that time were that device follow-up clinics integrate remote monitoring capability into their routine functions and include this service as part of the standard of care for device patients, ICD patients in particular. We suggest that in CID patients in whom no device issues are identified, that routine follow-up assessment is blended with remote monitoring in a 1-to-1 ratio after the 3-month post-implant assessment, of course, and that device clinics develop the infrastructure, resources, and policies and procedures to optimally support the remote monitoring program in a manner analogous to in-clinic assessment. So this is the number 3 is where I think we've failed somewhat, and we'll talk a little bit about device clinic burdens. Now, just other heart rhythm societies, the ERA expert consensus on remote monitoring was published in 2012, and they actually had no specific guidelines guidelines on remote monitoring at that time. And the HRS guidelines in 2015 recommended that all patients with CIEDs should be offered remote monitoring as part of standard management. And they felt that was a class 1 recommendation with a level of evidence A, and we'll review some of the evidence for the remote monitoring today. In addition, they recommended remote monitoring be combined with at least one annual follow-up in person over RM alone, and that patients need to be educated regarding their responsibilities and expectations with respect to remote monitoring, and that patients who have an advisory or recall should be enrolled in remote monitoring. And so these were all class 1 recommendations with varying levels of evidence, but certainly RM being as part of follow-up is level of evidence A. So here's the evidence base. Now this slide, I don't expect anyone to actually be able to read it. I just wanted to basically highlight the number of studies that have been done that are randomized trials in the use of remote monitoring. Most of them use daily remote monitoring. That's basically what we have our patients on when we hook them up to remote monitoring, as alerts would be transmitted daily if they ever occurred. And so a number of studies have utilized these systems with varying ejection fractions. Most of these patients were ICDs. In fact, all of these patients were ICDs. There were a few studies that included CRT patients, in time being the largest, and then using some other systems, there was a large proportion of CRT patients. The follow-up was variable, but at least 1 year in most cases. Now, when you look at a systematic review in 2015 of all these studies, which drove the recommendations from the HRS on remote monitoring, you find that in terms of overall mortality, that there is a slight benefit in towards remote monitoring, but it was not statistically significant when you put them all together. The only study that actually decreased mortality with remote monitoring was the In Time study. And they think that it had something to do, it had 59% of patients had CRT devices in that trial, and that perhaps it had something to do with heart failure therapy, and that improvement of heart failure therapy occurred in that trial in patients who had remote monitoring. When you look at cardiovascular mortality, again, a slight favor in benefit, but not statistically significant. However, when you look at the effect of remote monitoring on inappropriate ICD shocks, definite benefit. Atrial arrhythmia detection, not quite. There was a favoring of benefit with more atrial detections with remote monitoring. And then when it comes to time to clinical event detection to clinical decision, significant benefit in favor of remote monitoring. When you look at some cohort studies, we did one looking at patients who had a advisory from an Abbott device. So these are all Abbott device patients, and patients who had remote monitoring at baseline at entry into the study had a significant reduction in mortality compared to those who did not have remote monitoring at baseline. And so again, even when you look at it in a multivariate analysis where this is not randomized, you still had remote monitoring come out as significant in terms of predicting mortality. And other cohort studies have found this as well. And whether patients who have access to remote monitoring and can use it well do better, these are the questions that we have. But certainly there's good cohort data to suggest a significant benefit. Now, the only pacemaker study that we have that was randomized was back in 2012. There's a more recent one that I'll also present, but the COMPASS study was the initial study that looked at remote monitoring in pacemaker patients and found no difference in terms of safety. It was a non-inferiority trial in thousands of patients, over 2,000, and then found that 71% of follow-ups were non-contributory in patients who were monitored in clinic versus 38% of the remote monitoring group. So significant reduction in non-contributory follow-ups, and significant gain in event detection, primarily atrial arrhythmias in this study. Now, the Japan at Home monitoring study is a more contemporary study done in patients with pacemakers, and they had remote only follow-up with in-clinic at 2 years. and found no difference in their primary endpoint, which was safety. So remote monitoring follow-up versus clinic follow-up, no difference in terms of a safety endpoint, but they were able to have a significant decrease in in-office visits by 77%. There was no difference in actionable events, and in the number of visits with remote monitoring versus clinic follow-up were the same. So they actually were able to reduce in clinic by a significant amount, but keeping the remote monitoring not increased overall, which is of course what we all fear, but they were actually the same. Now, we've done a fair bit of work in remote monitoring and looking at what our clinics do in Canada. We did a device clinic survey and found that 80% of device clinics had some form of remote monitoring. This isn't the number of patients, this is the number of clinics that use remote monitoring. One of the things we found in the sort of key informant review was that our device clinic group think it's a better way to run a clinic and just do good care for patients, and that they think it's valuable, underutilized, underrecognized, and definitely a way of the future. 91% of patients said it was very important to receive a phone call from their device clinic after remote transmission has been received. And that feeds back to the loop that I was talking about, where we haven't been able to close the loop for patients in terms of having their remote monitor what that transmission actually means and feed that back to them. Some of the barriers that we identified in terms of remote monitoring is funding across jurisdictions. I believe Ontario still does not have a billing fee code for remote monitoring, a lack of a unified process specific and guideline supported approach after follow-up for devices, accessibility for all patients, resources in terms of education time and training in device clinics, coordinating care, the logistics around remote monitoring, and then attitudes toward remote monitoring visits in general. So we surveyed 512 patients as well across the country. These were primarily patients from Alberta, Quebec, and Nova Scotia. But what we did find is that patients did find that there were cost issues that interfered with their device follow-up, and this was more important for younger patients, obviously ones who might be out in the workforce, and then patients who lived further away. So patients who were beyond 50 kilometers found there were significant issues, no difference between men and women overall. Patients were mostly satisfied with their device clinic visits, but a lower satisfaction rate in younger patients, once again, may be related to some of these cost issues. And then we asked the question, would you feel secure if you did not have to go to the hospital and have your device checked? And again, younger patients felt primarily more secure that when they did not have to go to the hospital. Older patients were less accepting of remote monitoring, but we have to remember that we're planning for the future. So we're planning for those patients who will be older in the future and more accepting of technologies. Some of the patient quotes that we received in the survey is, I got no feedback as how the device was working or what the data was telling you about my health. At least when I have a live person gathering the data, I get some response as to how the device is working. Presumably, there's more data that can be given to me about my health, but not getting any information is annoying. And most of the time, I'm a no news is good news sort of person, but a comment such that this is the case is always nice. So patients really want to know what's happening with their device. They feel secure when they know what's happening. And that's something that we need to address with respect to remote monitoring. So our pilot study that we actually did a pilot study looking at remote monitoring only in patients with ICDs and pacemakers. We looked at safety, and at 12 months, there was the composite endpoint of death, stroke, cardiovascular hospitalization, or device-related hospitalization was 7.3%, which is significantly lower than the bar we set for ourselves, which was 12%. We saw a 58% reduction in in-clinic visits in patients who were in our remote monitoring only portion, but you can see this isn't zero. So patients still need to be seen for their device, and that's perfectly appropriate. We had no change in the number of remote transmissions in both groups. Patients had to have follow-up with a cardiologist or specialist as part of this study. We were not permitted to enroll patients if they did not have appropriate follow-up. These are sick patients with ICDs. The projected cost savings from this study was $660 per patient per year, amounting to over $23 million savings over 5 years. So this is projected. This is what we could potentially save if we went to a remote-only system in Canada. So that brings me to the burden of remote monitoring and our overburdened device clinics having to respond to multiple different aspects with respect to follow-up of patients. There has been some studies that have looked at remote monitoring and the clinic burden of remote monitoring versus in-clinic visits. And here, this was a study done in 25 centers in the US and Australia, looking at the proportion of visits that were remote versus in clinic and which devices contributed primarily to this. The main finding from this study was that ILR remote monitoring contributes a significant proportion to burden compared to pacemakers and ICDs, accounting for 18% of clinic burden, but only, I'll show you in this next slide, 5% of actual devices that were implanted. So ILR remote monitoring is a significant burden on clinics and certainly is something that we need to manage. Pacemakers, of course, are more common and so will contribute a more higher burden, but certainly compared to the ILR implants that we do and the burden it entails is significant. ICDs was, again, very reasonable. So the number of alerts that were red alerts, according to this particular study, was only 5%. So even though we're doing all of this transmission, most of the alerts we are seeing are not urgent. And again, managing that is going to be an aspect that we have to be able to deal with to not overburden our clinics. So only 1.7% of transmissions from all of the ILR transmissions were a red alert, and 18.1%, of course, were the majority of the transmissions. ICDs have about 6% of alerts that require an action. So again, we have to weed out these important alerts from the ones that are not important. And that particular study concluded that clinic restructuring is required. AI and machine learning will be needed to address all of this burden. So that brings me to the last topic I wanted to cover, which is cybersecurity, privacy, and medical legal implications. Again, we're moving into these areas of more remote monitoring. This was a study looking at all of the issues with respect to cybersecurity. Back in 2016, Muddy Waters research found that Abbott devices were subject to a cybersecurity vulnerability where increased radio traffic would cause devices in the Merlin product line to crash. This was a major issue that received a lot of media attention, led to a recall, and Abbott did install a firmware update to address this problem. But this overall problem, highlighted by Dr. Baranchuk's publication back in 2018, forces us to ensure that our patients are aware of these issues that can occur with respect to remote monitoring and how it might affect them. As we all know, cybersecurity, of course, is one issue. Privacy is another issue, and the fact that remote monitoring is transmitted to servers, particularly for patients in Canada, to the US, and that those servers are subject to the US Patriot Act. So patient information can be utilized without any patient consent based on the Patriot Act that was established back in the 2000s. And so from a medical legal standpoint, informed consent is critical. Addressing these issues regarding cybersecurity and privacy, the fear of liability shouldn't deter the use of remote monitoring, but we must consider the risks and benefits to our patients with respect to remote monitoring. So I want to close by just highlighting a study we're doing in patients with ICDs using remote monitoring only with a program called Virtues. Virtues is a virtual system that allows this feedback loop to occur quickly for patients. We've consented patients and told them about the privacy issues and medical legal aspects of what we're trying to do, and we're comparing it to standard of care. We have primary outcomes of cost, time to response, and safety, of course, to determine if a virtual system that allows us to do that feedback loop will improve our ability to manage remote monitoring. So why do I think remote monitoring only plus virtues is the best way forward? Well, I think we'll improve quality of life. I think we'll have more rapid detection of arrhythmias. We can focus on device programming and optimization and providing immediate feedback to patients. I'm hoping we can improve heart failure care. There's a heart failure component to the study, and I believe it's as safe as in-clinic visits, and I hope it will result in enormous cost savings. So I will end there. I think RM is here to stay. We have to embrace the technology. We have to figure out how to improve it and manage our clinics accordingly and make this the best way for patients with CIDs. Thank you very much. I'd be happy to answer any questions.
Thanks a lot, great presentation. Do we have any questions in the chat?
We do have questions in chat. Dear Dr. Prakash, thank you for your valuable talk. On behalf of Andres Miranda Arboleda, do you have previous experience in remote device programming changes or deactivation in terminally ill patients with limitations to move to device clinics?
Yeah, that's a very good question and a significant issue as our patient population with ICDs are aging. Yeah, the remote device programming, I've had a lot of conversations with the device manufacturers about this, and there's no way that we are going to be able to do this in our current environment. We may move towards it as time goes on, but the deactivation in terminally ill patients, I think that if we work with some of our satellite clinics in the community, for example, in Ontario, there's a huge number. We have a number in Nova Scotia, and I know in Alberta and BC, it's similarly done, that we can work with clinics to deactivate these remotely. There is one technology that Medtronic has called Remote View, where you can actually view the screen that the person is in a remote site. It's transmitted over the web. To view the screen, you can make sure that the programming is turned off. The other way to do it is to obtain a transmission after programming changes are made to make sure that it's turned off. And I think we can do this for patients who can't move out of their community to get this done.
Thank you. One more question that I'd like to squeeze in before we move on. What about iPhone and interaction with pacemakers and ICDs from Martin Strauss?
Yeah, that's an excellent question. And we actually just issued a CHRS notification on that. And so the most recent iPhone 12 in particular has a large a magnet as part of the phone to allow charging to be wireless. And that has resulted in interference with devices, but you really do have to place the phone right over the device to result in interference. And so, myself and I'm sure everybody else on this call has always told patients to keep their devices 6 feet away from their cell phones 6 feet away from their devices to prevent that. And that teaching hasn't changed based on the current changes in iPhone technology. So just tell your patients don't put it over their device. But yes, those magnets are pretty powerful in the iPhone 12 and can interfere with the function of a pacemaker and cause a magnet response.
Okay, thank you so much. Thank you to our wonderful faculty on these stunning presentations, and of course to our moderators for moderating very engaging Q&A questions. Before I give the word to Dr. Crystal for his final remarks, we have a few questions to improve our International Arrhythmia School event sessions, and I will put up the first question. If you could please respond to this, then we will be able to, and I see 100% already answered. I will share the results just quickly. So we have, what do you think about the duration of this event? And the most people think it's just right. A minority feels it's too short. Let's move on to the next question just quickly. We have a question for you on what the COVID situation is. Should it improve, would you join a face-to-face version of this meeting? If you could respond to that. So let me just share the results. We have a yes for about 60% and 40% is still hesitant. Let's move on to the next question that we have. It is regarding, did you enjoy this event? We would be very interested to know this. Let's share the results. Many people seem to enjoy this event, for which we are very, very happy. And let's move on to the next meeting question, because should we want to do another event like this, which day of the week would be best for you? It's very important for us to know. I see that mostly the weekends are preferred, the Sundays or the Saturdays, a minority on Fridays. Thank you so much for responding to these. This really helps us make better events in the future. Then the fifth question, would you recommend this program to others? And I share the results that luckily many people feel that this session is worth recommending to others, and we hope you will do that in future events as well, of course. And then the final question already, thank you so much for all this information that you're giving us. Was the information provided in the program current and clinically relevant to you? And let me share the results. And we're very pleased to see that the content was current and clinically relevant in this session. So thank you so much for all this information that you have shared with us. And I'm giving the word and microphone back to Dr. Eugene Crystal. Dr. Eugene.
Guys, thank you. Thanks a lot. Thanks for faculty. Radhika, thank you for helping me with that. I'm just thrilled to thank Anthony, who joined us for the first time, Adrian, who's always inspirational, and David, with whom we don't see each other in the lab for several months at least. I'm extraordinarily pleased for everybody talent contributing. I hope we will be reconnecting with all of you soon and face-to-face February 2023. Thank you.
Thank you very much for joining today's program. A warm thank you to everybody who joined and the faculty as well as the organizers. We heard some very interesting science discussed today, and a heartfelt thank you to all of you. And we hope to see you back in future events. Keep an eye on our website and social media channels, and we hope to welcome you soon at one of our future events. For now, the rest of your day, please enjoy, and we'll see each other soon. Goodbye.